Yes, so very good evening, boys and girls. Let's get connected again today with the Premier League, which we had started yesterday. Okay, so today again we'll have uh, so today again, we'll have the MCQ session based. We're going to have an MCQ revision we'll have, and we'll be covering certain very important topics which we had started yesterday. Okay, so let's get started with the first topic for the day. Here is your mentor, Dr. Reena. Now, the first thing which I'll be taking you with will be your cystometrogram. So there are n number of questions which had come on the cystometrogram, right? There were n number of questions which were which had come in the cystometrogram from the last 2 to 3 years, right? From the last 2 to 3 years, and I'll be just explaining you like what questions can come. हाँ ठीक है, तो अभी इस पे क्वेश्चंस क्या थे? Am I audible, visible? Any everyone? Am I audible and visible? Just let me know so that we can have a smooth class. Yes, if anybody from could just respond me so that I can really have a smooth class. ठीक है, सब कुछ ठीक चल रहा है. Okay, anyone? Okay, so thinking that everything is okay, I'm moving on. Now, the different questions which I can ask on this cystometrogram would be, like, I can ask you, first important question is, right, I can ask you that at which urine volume, okay, at which urine volume there is going to be the onset of the maturation reflex, or the question can be which segment in the cystometrogram, is depicting the law of Laplace, or suppose there is an overactive bladder, ठीक है, if there is an overactive bladder, which segment of the cystometrogram, okay, which segment of the cystometrogram will not be affected, right? Which segment of the cystometrogram will not be affected? So these could be the different questions. This could be the different questions which can come from this. ठीक है? Now, good evening Kshitij. Yes, Kshitij, आपने preload afterload बोला था, वो भी I'm going to teach, don't worry. Okay, I'll be teaching the preload afterload also. Now, first of all, what is this cystometrogram? The cystometrogram basically represents a graphical representation, ठीक है? It is a graphical representation of the pressure volume relationship of the bladder. Pressure volume relationship of bladder. So in physiology, whenever you get any graph, the first thing which you should look about is what is on the x-axis and what is on the y-axis. That is the key in all graphical questions that is related to physiology. So on the x-axis we have got volume, and on the y-axis we have got the intravesical pressure, which is in centimeters of water. ठीक है? Now you can see that different segments are given, which are written as 1A, 1B and 2. Now remember that when we start the cystometrogram, we must remember that we are having the detrusor muscle, that is the smooth muscle of the bladder. So definitely, because like yesterday also I had taken a question on the MCQ that was based to smooth muscles. Smooth muscles have got their own different relationship as compared to the striated muscles. So first let's study cystometrogram, and then we'll jump on again to the Laplace law. You can see that as a small volume of urine accumulates, there is an abrupt rise in pressure. So there is an abrupt rise in pressure with accumulation of small volume of urine. But even now, if you keep on increasing the urine volume or experimentally भी अगर आपने fluid infuse किया, if you want to study this cystometrogram, you will see that even after increasing the volume, the pressure remains the same. That means you attain a plateau, right? You attain a plateau. So the pressure remains the same. You attain a plateau. That means what the detrusor muscle is doing, it is receiving that increase in the urine volume without increase in pressure, and this property is what is called as receptive relaxation, right? This property is called as receptive relaxation, which is an inherent property of the smooth muscles, and the plateau phase, which is depicted as 1B, right? The plateau phase, which is depicted as 1B, is actually indicating you the law of Laplace. So we have solved one question, that this plateau phase, what is this, which is 1B segment, is nothing but the law of Laplace. So we can see that with increase in the volume, there is no no consistent rise in pressure. But again, as the urine volume becomes 400 ml, there is now going to be active contraction of the muscles. So if you take this same figure from Guyton, ठीक है, अगर आपने Guyton में से ये cystometrogram पढ़ा, तो Guyton has, you know, shown these maturation waves. Okay, it has shown these maturation waves. So at 400 ml, there is active contraction of the muscle. The pressure will now rise. The pressure is going to surpass the pressure of the sphincters, so that the maturation reflex can be brought about, right? So 1B is depicting nothing, that is the law of Laplace, and 400 ml of urine is going to be the urine where there is going to be the onset of the maturation reflex. That means you get a sense of fullness. Okay, so 150 ml of urine is the urine where there is a first urge to maturate. First time, matlab the subject wants to go for the nature's call, but you can hold the urine, and again 400 ml may there is going to be a sense of fullness, and this is the time where we now need the bladder to be evacuated, right? So this is important. Now what is the Laplace law and what is the feature of the smooth muscle, which I told you that the smooth muscle, it shows nothing but which we called as the smooth muscle plasticity. So the Laplace law is nothing but the Laplace law says that P is equal to T, that is tension, is equal to P into R. Let us make it very, very simple. So T stands for the tension that is being developed, P is the distending pressure, and R is the radius. So what happens that as the volume in the bladder increases, right, that means there is an increase in the R. There is receptive relaxation. The smooth muscles, they will develop tension. That means they will increase the T. So with increase in the R, there is going to be increase in the T, and the pressure remains constant. So despite of increase in the urine volume, by bringing about an increase in the tension, they keep the pressure constant. This property of the smooth muscles is receptive relaxation, which is not only seen in the detrusor, but it is also present in the stomach, wherein the stomach can accommodate large volume of food without increase in the pressure. Again, what is the reason? As we had studied yesterday, that these smooth muscles, they can exhibit active tension. They can exhibit active tension at any length. So it is not specific that jab sarcomere ka length should be so and only then the active tension will be developed, as in the case of striated muscles. यहाँ पर कैसे होता है, even at smaller length or even at more length they can develop active tension because the ratio of actin to myosin is more as compared to striated muscles. In the striated muscles the actin is twice myosin, right? But here in the smooth muscles the actin is about 10 times more than myosin. So even if the myosin is aligned in any direction, it will always have actin to bind. They show a very different length tension relationship. So this is the cystometrogram. And what questions did I put forth to you? I asked you about this segment, this plateau, that is Laplace law, 400 ml where there will be maturation reflex. The first urge will be at 150 ml, and this stage B, which is plateau, okay, will be affected in the person who has got an overactive bladder, right? So these are the questions which are related to your cystometrogram. Then the second very important question that is related to your to your renal physiology is clearance. It is very important. Now what is clearance, right? So by definition clearance is the volume of plasma, right? It is the volume of plasma that is cleared of a particular substance per unit time when the plasma flows through the kidney. So it is not the substance that is getting cleared, it is the volume of the plasma that is getting cleared. This formula is a very important formula. You can just check on with your NEET PG questions and you will find simple things had been asked, as simple as what is U. तो आपको पता होना चाहिए कि U is the urinary concentration of the substance. So if we look on to our if we look on to the formula, clearance is urinary concentration of a substance divided by plasma concentration of a substance into urine flow rate, wherein the clearance will be in ml per minute. This is the first thing to be known, that what will be the answer. It will be in ml per minute. U stands for urinary concentration of the substance. P stands for plasma concentration of the substance. The values will be milligrams per ml. It could be even milli equivalents per ml, it could be millimoles per ml, but it is not per minute. And whenever we are doing calculation, please ensure that the values and the units, especially the units of the U and the P, are same. Then urine flow rate is in ml per minute. So ux and px, इनका milligrams per ml gets cut, cancelled when we solve this, and therefore the value of clearance, it comes as ml per minute. This is very important. ठीक है, मतलब just don't take कि मैम कितने सिंपल चीज को बार बार बता रही है, but I really tell you that this question is very important, right? Now suppose I give you a question wherein I ask you to calculate the reabsorption rate, right? I ask you to calculate the reabsorption rate, and I give you GFR is equal to 50 ml per minute, right? The urine flow rate is 1 ml per minute. The plasma concentration of urea is 2.5 milligrams per ml, and the urinary concentration of urea is around 50 milligrams per ml. So with this data, can you calculate the reabsorption rate? Similarly, I can also tell you to calculate the excretion rate, or I may tell you to compare these values with that of inulin. ठीक है? So they are very simple. You just need to have the very apt formula. So what is the formula, right? So the formula is Suppose you have to calculate the reabsorption rate of a particular substance. The reabsorption rate of the particular substance is the filtered load. Okay, it is the filtered load minus excretion rate, माइनस एक्सक्रीशन रेट. ठीक है, सो अगर आपको किसी का रीअब्जॉर्प्शन रेट कैलकुलेट करना है, यू विल हैव टू सबट्रैक्ट द फिल्टर्ड लोड फ्रॉम द एक्सक्रीशन रेट. एंड सपोज if you have to calculate the secretion rate of any substance, then you will have to subtract this. That will be excretion minus the filtered load. Now how will I calculate the filtered load and how will I calculate the excretion rate? So remember that the filtered load is nothing but the filtered load is nothing. It is GFR into plasma concentration of substance. It is GFR into plasma concentration of substance, and the excretion rate is urine flow rate into urinary concentration of a substance. So now since you've known the filtered load, you've known the excretion rate, you can just calculate the two loads and use the appropriate formula which is given. That is how to calculate the secretion rate and how to calculate the reabsorption rate. Okay, so again these are again very important calculation based questions with your physiology, especially you know you are asked to calculate the tubular, the TM maximum for glucose and all. Then one important graph which is given is like this. So these are the clearance graphs which are depicted over here, and suppose I give this A, B and C, and I ask you out of this which is the clearance of PAH, that is paraaminohippuric acid, a substance which is secreted. तो आप क्या बोलेंगे? Yes, Kshitij? What will be the answer? Anybody? A, B or C? A. Very good. Now let's look into that why it would be A. So this is very important clearance curve and very important hidden concepts which are over here. Now see, so this is your clearance graph. Again जैसे मैं आपको बोलती हूँ कि जब भी कोई ग्राफ आता है, always look into the x and y. So at x we've taken the plasma concentrations and on y we've taken the clearance in ml per minute. ठीक है? Now let us first see with glucose. See, this horizontal straight line is with inulin, because inulin is a substance which is neither filtered nor secreted, and therefore the clearance of inulin will be same as that of GFR, that is 125 ml per minute, because it is not reabsorbed, it is not secreted. Now check on to glucose. As the concentration of glucose is within the renal threshold, that is 200 milligrams, there is 100% reabsorption of glucose. So the glucose will not appear in urine. But as the plasma glucose concentration rises, what happens? The clearance increases. The clearance increases. Again I repeat, as the plasma concentration of glucose rises, the clearance increases. What is the reason? The reason is very simple. There occurs saturation of the carrier proteins which are going to reabsorb your glucose. So because there is a saturation of the proteins, 100% glucose is not reabsorbed, and therefore small amount of glucose, after being reabsorbed, the remaining is excreted or secreted in urine, and therefore the clearance graph is increasing. Now, second important thing which I want to make you highlight is that this is inulin, right? And this is glucose. That means inulin and glucose, after some time, they are going parallel. However, the glucose clearance will always be less than that of inulin. It will always be less than that of inulin. So what is the reason that namaste ma'am, namaste medico, it's very sweet to hear the word namaste. Namaste, thank you. Okay, so my question is that though the clearance of glucose is increasing, right, it is becoming parallel to inulin, but why not? But why not it is totally coinciding with inulin? Why it is not? It is because inulin is a substance that is only filtered, right? Inulin is a substance that is only filtered, whereas glucose is a substance which is filtered plus reabsorbed. So even if the glucose concentration in the blood rises from 100 to 200 to 300, there will always be small amount of glucose which will always be reabsorbed. लेकिन inulin बिल्कुल भी reabsorb नहीं होता है, इसीलिए the clearance of glucose is going to be parallel to inulin but never equal or never touch inulin. Now, if we consider the PAH, you know that PAH is a substance which is secreted. So even though it is secreted, it is using carrier proteins. तो इसमें क्या होगा that as the concentration of the paraminohippuric acid increases, right, the clearance decreases. So this is very interesting that for a substance that is reabsorbed उसका clearance बढ़ जाता है, लेकिन अगर कोई substance है जिसको secrete होना है and it is using carrier proteins, तो उसका clearance कम हो जाएगा. क्यों कम हो जाएगा? Because its secretion also needs carrier proteins, and if its concentration becomes more, there is going to be saturation of the carrier proteins, and इसीलिए जितना clear उसका volume होना चाहिए plasma का out of pH, it is not getting that, and the clearance of PAH decreasing. Again the same thing, the PAH clearance is going parallel to inulin. ठीक है, it is going parallel to inulin, but it is not touching inulin. It is not becoming equal to inulin. What is the reason? Because paraminohippuric acid is a substance that is filtered plus secreted, whereas inulin is again only filtered. So even if there is increase in the plasma pH concentration, small amount will always be secrete. So the clearance will decrease but always be parallel to inulin, and it will not touch inulin. So remember, अगर कोई भी substance को reabsorb होना है, ठीक है, तो उसका clearance बढ़ जाएगा, और अगर कोई भी substance को secrete होना है तो उसका clearance कम हो जाएगा. This clearance वाला graph was also the last NEET PG question, और ये वाला topic is again very important. Now suppose I say you that what is the normal clearance of glucose. अभी मेरे को समझ में आ जाएगा आपको समझा कि नहीं समझा. It is, remember the clearance is in ml per minute. So how much is the normal clearance of glucose? 0, 70, 125 or 10? बोलो मेडिको. Yes? Very good, Kshitij. So Kshitij should be given something, isn't it? Kshitij ने फटाफट जवाब दिया है. So let's give Kshitij a piece of cake. Very good. Yes. Very good, Shahu, Pihu. Very good. The clearance of glucose is 0. That means normally no glucose is coming in urine. That means all the glucose is getting reabsorbed. So if it rises, then again there is failure of reabsorption. Very good. Chalo, next question. Okay, now a 16-year-old girl is brought with a head injury because of a car accident. She's brought to the emergency department. She has got a respiratory rate of 8 breaths per minute and a prolonged duration of inhalation was noted. This is the key. Prolonged duration of inhalation. This is the key to this question. Damage to which of the following is likely to produce this type of abnormality? DRG, nucleus tractus solitarius, pneumotaxic center or the vasomotor center? कौन जवाब देगा फटाफट? Who wants to win a cup of tea? Who wants to win a piece of cake? जल्दी जल्दी बोलो. Yes, पीहू. क्षितिज, कहाँ पे प्रॉब्लम रहेगी बेटा? Okay, so the correct answer is C, that is pneumotaxic center, right? Pneumotaxic center, Kshitij, क्योंकि the clue was that the duration of inhalation is increased. Very good, Pooja. Yes, very good. Now, what is this pneumotaxic center doing? The pneumotaxic center, which is present in the upper pons, okay? The pneumotaxic center, which is present in the upper pons, controls through an inhibitory signal to the apneustic center, right? It keeps the activity of the apneustic center in check. So as we inflate and the lungs get inflated and they are stretched, the signals are going to come via the vagus to inhibit the apneustic center and also from the pneumotaxic center to inhibit the apneustic center. So the apneustic center now will not be able to stimulate DRG. Normally the apneustic center gives a constant signal to the DRG to continue the inspiratory drive. But at very appropriate time when the lungs are full with air, the pneumotaxic center is going to inhibit the apneustic center, and the main role therefore of this pneumotaxic center is to switch off the inspiratory ramp signal, okay? Is to switch off the inspiratory ramp signal, that is bring about a very smooth transition from inspiration to expiration, bring about a very smooth transition from inspiration to expiration. So this pneumotaxic center is controlling your rate and depth of breathing, right? It is controlling the rate and depth of breathing. Therefore, if you stimulate the pneumotaxic center, the increase in the respiratory rate will be associated with a decrease in the tidal volume. And if you inhibit the pneumotaxic center, there is a slowing of the respiratory rate with increase in the tidal volume. So these are the various neural centers for your regulation of respiration. So what are the different centers? These centers are medullary centers and pontine centers. So in the medullary centers, you have got DRG, that is the dorsal respiratory group of neuron, which is supposed to start the inspiratory ramp signal. It is in the form of a ramp which helps in the gradual filling up of the lungs with the tidal volume. Therefore, it is called as a ramp. So, ekdam sudden 500 ml tidal volume is not going to fill up the lungs. Slowly, gradually we fill up. Then the second one is the VRG, that is the ventral respiratory group of neuron, which remains silent in normal respiration. That is eupnea, or the normal breathing does not require VRG. It comes into play only when there is a forceful expiration. For example, you are trekking, you are at high altitude, you are exercising, those conditions, right? And उसके बाद you have got your PBC, that is the the pre-Botzinger complex, which is supposed to be the pacemaker, which is controlling the rhythm of breathing, right? Which is controlling the rhythm of breathing. As far as the pontine centers are concerned, you have got pneumotaxic center in the upper pons, which is regulating your apneustic center, and the apneustic center in the lower pons, which always gives a constant drive to the DRG, so that the DRG can bring about spontaneous onset of breathing. However, the activity of the pneumotaxic center, the activity of the apneustic center is kept in check by vagus and by the pneumotaxic center. तो दोनों में से किसी एक को present होना चाहिए, otherwise there will be apneusis. Shubham, Shubham is sending spectacles and Shubham is sending smileys. What does all that mean, Shubham? Gupta, can you tell me क्या है इसका मतलब? What is making you happy? Something? Now come to chemical regulation of respiration. The chemical regulation of respiration is with the help of our chemoreceptors. These chemoreceptors are peripheral and central. The central chemoreceptor is present on the ventral surface of medulla, just near the DRG, and the peripheral chemoreceptors are the carotid bodies. Remember, bodies, not sinus. Sinus are the baroreceptors. The carotid bodies and the aortic bodies, which are supplied by the 9th and by the 10th nerve. Very good, Shubham. Now, if you consider the carotids or the aortic, suppose A and B, which is more important? Can you tell me that which is more important or which is doing its work more significantly, A or B? Yes, anyone? A or B? Whether the carotids are more important or the... Yes, very good, Shubham. It is the carotids, because the carotids, they regulate both the rate as well as the depth of breathing. Another important thing which we must remember is that they have got glomus cells. These glomus cells have got hypoxia sensitive potassium channels. So as soon as there is hypoxia, there is stimulation of the hypoxia sensitive potassium channels, which close, which prevent the efflux of potassium, creating depolarization, entry of more calcium, release of neurotransmitters, and firing through 9th and 10th nerve. ठीक है? Now, what is the most sensitive stimuli to this peripheral chemoreceptors? Yes, Shubham. सबसे important is a decrease in the oxygen, decrease in the partial pressure of oxygen, especially when the partial pressure of oxygen becomes less than 60 mmHg. Okay, less than 60 mmHg. Why 60 mmHg is important? Because this is the point where the oxygen saturation is 90%. As soon as it becomes less than 60, the person's saturation keeps on decreasing. So most sensitive is oxygen, then that is hypoxia, then you have got CO2, H plus ions, potassium, even lactic acid, cyanide poisoning, and even nicotine. Remember that progesterones, okay, progesterones also increase the sensitivity. Progesterone also increase the sensitivity of the peripheral chemoreceptors to the chemicals, and therefore in the late half of the menstrual cycle or even during pregnancy there is an increase in the breathing rate. ठीक है? Now, इस पर एक बात और हमको याद रखना चाहिए, because we've seen the different factors and we've seen the hypoxia. Remember that all types of hypoxia They stimulate the peripheral chemoreceptors except anemia, that is anemic hypoxia. So anemic hypoxia does not stimulate the peripheral chemoreceptors, and therefore even in carbon monoxide poisoning, which is a type of anemic hypoxia, will not stimulate the peripheral chemoreceptors. ठीक है. As far as the central chemoreceptors are concerned, जैसे शुभम ने पहले से ही बोल दिया, they have got no role in hypoxia. That means they have no sensitivity to a decrease in the oxygen. They are sensitive to partial pressure of carbon dioxide in the blood, but the actual stimulus is the raised hydrogen ion concentration, which is actual hydrogen concentration in the CSF. Yes, Shubham, in anemia, what is more important is that oxygen carrying capacity is decreased, but the dissolved oxygen is normal. The peripheral chemoreceptors, they respond to the oxygen tension that is determined by the partial pressure of oxygen, right? And therefore, whenever there is anemia, okay, anemic hypoxia, where the partial pressure of oxygen is normal, the oxygen tension is normal, so the peripheral chemoreceptors need not get stimulated, right? Now, there are so many reflexes. Bapre. Thank you, ma'am. Thank you, Shubham. Shubham. Yes, thank you. Now, there are so many reflexes which are important as far as the respiratory system is concerned. You study the the Herring-Bloor deflation reflex, all those reflexes you study. बट मेरे को सबसे इम्पॉर्टेंट रिफ्लेक्स जो लगता है, जो आपको पता होना चाहिए, दैट रिफ्लेक्स इज द जे रिफ्लेक्स. J reflex, because this reflex is due to the J receptors which were discovered by the Indian scientist AS, that is Avtar Singh Paintal. Now suppose this is your alveoli, right, and this is your pulmonary capillary, and just juxta to the pulmonary capillary, this is your J receptor. ठीक है, this is my J receptor. We'll make it more colorful. Yes, this is my J receptor. So remember, the J receptors are unmyelinated type C fibers. They are unmyelinated type C fibers. These receptors get stimulated whenever there is fluid over here, right? Whenever there is fluid, so they are going to get stimulated with edema, with embolism, and they result in what we call as a J reflex, which is characterized by apnea, breathlessness, with hypotension and bradycardia. So they are important in pathological conditions, but they are again very important in a physiological condition. For example, if there is a severe exercise being done, especially in a normal subject who is at high altitude but who is not acclimatized, right, who is not acclimatized but he is at high altitude. So because of this J reflex brings about a feeling of dyspnea. It brings about reflex inhibition of the motor neurons, reflex inhibition of the alpha motor neurons, and brings about a relaxation of the muscles. So the person is going to terminate exercise because of an unpleasant feeling of dyspnea, and it brings about reflex inhibition of the alpha motor neurons. So that is the role of the J reflex in high altitude unacclimatized person who is exercising. Again, if you remember the Bhopal gas tragedy, which was in 1984, there was the chemical MIC, that is methyl isocyanate, wherein the people, they developed the stimulation of the J reflex with breathlessness. So Bhopal gas tragedy, maybe this receptor was involved, right? Now if this type of a graph related question comes to you, ठीक है, जहाँ पर आप एक composite graph देखोगे, you will see that various conditions are being shown. So many times I have taught you the the composite effect of pH, H plus and oxygen and carbon dioxide, and I have told you that the presence of carbon dioxide will increase the sensitivity of the chemoreceptors to hypoxia. But यहाँ पर याद रखना, when there is more of the left shifting and steepness, it mainly includes increase in ventilation. So acidosis, increase in ventilation, suppose this is normal. Sleep, narcotics, anesthesia, they're going to cause a suppression of the alveolar ventilation. So this type of a graph should be kept into mind, boys and girls, if you get a graph related question. Now moving on, next is these are the three peak flow volume curves being given to you. X-axis volume, Y-axis air flow in liter per minute, and out of this A, B and C, which one, I'll just read out and you will have to tell me which one is A. Okay, which one is A? The question says that 75-year-old man who has smoked 2 packs of cigarette per day for 60 years, his breath sounds are decreased bilaterally and the X-ray chest flattening of diaphragm. So this is A. Or B, a 68-year-old person with dry cough has a history of asbestosis or pulmonary fibrosis, or a patient with myocard infarction, or just a normal healthy person who has come for a routine physical examination. So since the graph shows very beautifully this curved, we come to know that it is definitely obstructive kind of a pathology, and the correct answer becomes A, that is a 60-year-old person who has been smoking cigarette. Yes, Kshitij, very good. Now when we speak to the peak flow rates, right? So peak flow rates mein, this is inspiration starting from empty lungs, that is residual volume. This is going to be my TLC, you have filled up the lungs, and this is my expiration, and this is completion of the expiration. This portion, the peak, is the peak expiratory flow rate, and this becomes nothing but what we called as the effort dependent. Okay, effort dependent portion. That means if the person blows out or expires out with more and more effort, that part can be increased, right? That part can be increased, or the peak can be increased. So remember that whenever there is a large volume of air, the seat of resistance, or we will be speaking of the large airways. But this portion where there is a small volume of air which is coming from the small airways, this portion will be our effort independent portion, right? Effort independent portion. Now if any time you get a graph, right, suppose you get a graph, how will I come to know that whether it is obstructive, whether it is whether it is obstructive, whether it is large airways, or whether it is the small airways? कैसे पता चलेगा मेरे को कि वो large airways है या वो small airways है? Now if you are given so if you are given a peak flow rate, inspiration is normal, and you see that the height is reduced as compared to normal, there is only a decrease in the height as compared to normal, right? There is only a decrease in the height as compared to normal, but there is no concavity. there is no concavity, there is only a decrease in the height and there is no concavity. So if there is only decrease in the height, that means a significant decrease in the PEFR. The seat of obstruction is the large airways. Okay, the seat of obstruction is the large airways. But if you get a graph where the peak of the PFR is good but a typical concavity is seen, then this is the small airways, right? So if only the height is reduced but no concavity, it is larger airways. लेकिन अगर height of the PFR is normal और concavity है तो it is small airways. But by and large in obstructive airway disease you get a combination of small and large obstruction, and therefore you get a decrease in the height as well as you get a concavity. In restrictive lung disease, why the PFR is reduced? Because in the restrictive lung disease the main problem is that the compliance is reduced. That means the lungs have got less volume. तो अगर lungs में already volume less है, आप कितना भी effort दे देंगे, you cannot increase the height of PFR. So you're going to get a small one but a normal shape with restrictive lung diseases. ठीक है? Now, next one. There is a patient with Virginia's glomerulonephritis who presents with sinusitis with hemoptysis. Chest radiograph shows large cavity pulmonary nodules which is consistent with ventilation perfusion imbalance with a low VQ. Which of the following will be greater than normal in a subject with a low VQ? Options A, that is alveolar arteriolar gradient, partial pressure of carbon dioxide, oxygen, dissolved oxygen in the blood, or oxygen combined in hemoglobin. So what will be the correct answer for this? Yes, Shubham. Anybody would like to come? So the correct answer for this question is going to be the alveolar arteriolar gradient. Yes, Shubham, very good. The alveolar arteriolar gradient. So areas with a low VQ ratio produces hypoxemia or a decrease in the partial pressure of carbon dioxide, which leads to a decrease in the dissolved oxygen content of the blood and a decrease in the partial pressure of carbon dioxide. That is because of the stimulation of the peripheral chemoreceptors. At low partial pressure of oxygen, the arterial oxygen saturation is decreased, which will also decrease the oxygen hemoglobin content. And because the mixed alveolar PO2 is normal, the arterial PO2 is less than normal, and therefore the alveolar oxygen gradient will be more than normal. So what is this alveolar arteriolar oxygen gradient, which we also called as the alveolar gas? First we have to calculate the alveolar gas equation from that. Now to understand this, let us make it very, very simplified so we are able to even solve calculation based MCQ. So if you have to calculate the oxygen content or the percent fraction of oxygen or the partial pressure of oxygen in dry air, right? So if you have to calculate the partial pressure of oxygen in dry air, that means humidified nahi, in the atmosphere, what formula you take? You take the percent fraction of the gas into 760 if it is sea level. And suppose if you are at high altitude or if you are at lower altitude, then obviously you will have to see over the barometric pressure, right? Now it is 21 by 100 into 760, that comes around 159 mmHg. Now if you have to calculate this in the inspired air, which is nothing but the humidified air. That means now you are subjected to a partial pressure of 47 mmHg, that is the water vapor pressure. So it will be the fraction of gas that will remain constant, that is 21%. Subtract subtract the partial pressure of water vapor from atmospheric, and this comes to 150. So this is with when you calculate in the when you calculate for the inspired air. But as you calculate in the alveoli, when you calculate in the alveoli the partial pressure of oxygen, which we also called as the alveolar gas equation, in that case the partial pressure of oxygen will be the fraction of oxygen atmospheric pressure minus the pressure of water vapor. Now you will have to subtract other things, that will the partial pressure of carbon dioxide, because in the alveoli there will also be carbon dioxide, which will further decrease your oxygen. The amount of carbon dioxide depends upon the metabolism, that is the RQ or the respiratory quotient. So this is going to be the oxygen in the alveoli, and you see that this oxygen in the alveoli is around 104 mmHg. But when you take an arterial sample, right, when you take an arterial sample, you will find that the oxygen in the arterial sample is never 104. It is further decreased. It comes to around 95 mmHg, right? This is because of the small amount of the venous admixture that we also called as physiological shunt. You know that the bronchial veins, they also empty into the into the pulmonary veins, and therefore this results in a small amount of venous admixture, and therefore the alveolar arteriolar gradient is between 5 to 15 mmHg, and this is going to be increased in conditions when there is ventilation perfusion mismatch, or right to left shunt, or increase in the thickness of membrane, right? Remember that the alveolar arteriolar gradient is going to be normal at high altitude, because in high altitude whatever oxygen we are taking itself is less. Okay, it is going to be the oxygen which we are going to take less. There is no problem with the exchange of gases. Now moving on to the next very important topic is what is the oxygen hemoglobin dissociation curve. Now this curve is typically a sigmoid shaped curve. The sigmoid shaped curve is because of a changing affinity. Changing affinity means what? We know that the deoxyhemoglobin, okay, the deoxyhemoglobin, the globin molecules are very tightly or compactly present. That is called as a tense configuration. And as one molecule of oxygen binds, it facilitates the binding of the second will facilitate the binding of third, and the third will facilitate the binding of the fourth. So the binding of the fourth molecule is easy, and from the tense configuration we take it to a relaxed configuration. So this TR conversion is changing affinity, which is also called as cooperative binding, right? It is also called as cooperative binding, and that is the reason for the sigmoid shaped curve. Now this value is of utmost important, that at partial pressure of 60 the person's saturation is 90%, because it is up till this value that the person will never suffer from hypoxia, okay, never suffer from hypoxia. Therefore when we are moving at high altitude, we say that 10,000 to 12,000 feet is a safe ascent, because up till that time the partial pressure of oxygen is maintained at 60. उसके ऊपर अगर हम जाते हैं तब partial pressure कम हो जाएगा, person saturation कम हो जाएगी, and there will be hypoxic hypoventilation. You can just remember this rule of 4, 5, 6 and 7, 8, 9. That is, when the partial pressure of oxygen is 40, 50, 60, the person's saturation is 70, 80, 90. This small rule can be kept into your mind, right? Now, what is the significance of this plateau and what is the significance of the steeper portion? So this plateau, okay, this plateau basically tells us what? This plateau actually tells us saturation as well as a safety factor. What is saturation? See, you can see that even if you increase the partial pressure of oxygen from 60 to 100, right? Even if you increase the partial pressure of oxygen from 60 to 100, the person's saturation will increase only from 90% to a maximum of 100%, because 100% means abhi full saturation ho gaya hai. Likewise, what is the safety? Suppose if you are at sea level and you have got 100% saturation, you keep on moving to high altitude and you keep on dropping your partial pressure of oxygen, and even if your partial pressure of oxygen decreases from 100 to 60, the percent fall in saturation is only 10%, from 100 to just 90, that is only 10%. So it is depicting not only a saturation but also a safety factor. This steeper portion, this is the portion that shifts to the right or to the left depending upon the different factors. So the different factors which amount to the right shift. Remember, right means more. R. What more? More carbon dioxide, more temperature, more DPG and more H plus, right? Whereas left means less. What less? Decrease in carbon dioxide, decrease in temperature, DPG and alkalosis, right? So this is the right and the left shift of the curve. With carbon monoxide you get a left shift. The reason is that carbon monoxide has got affinity about 200 to 250 times more than oxygen to hemoglobin. So carbon monoxide promptly binds to the oxygen binding sites of hemoglobin, and it does not allow any more oxygen molecules to get bounded, right? So what happens, that because it does not allow more oxygen to get bounded, the oxygen which is already bounded also gets scared because of this competition, so they do not get released. That means once the carbon monoxide is bounded, oxygen cannot bind to hemoglobin and the bounded oxygen cannot release. ये important factor है कि न्यू बाइंड भी नहीं होने वाला है और जो ऑलरेडी बाउंडेड है वो रिलीज भी नहीं होने वाला है, ठीक है? Now you will have to differentiate the carbon monoxide का left from other left. Whenever there is a confusion, always remember that oxygen content will be grossly reduced in carbon monoxide poisoning. Whereas if you consider the curve with the fetal hemoglobin, the oxygen content is not going to decrease, but oxygen content will be decreased with carbon monoxide poisoning. Now, before I take more, as Kshitij had asked me to teach what is preload and what is afterload. So preloaded condition is a load is a condition where the load is acting on the muscle before the muscle begins to contract, right? So पहले से ही आपने load लगा दिया. Suppose you've picked up the bucket. Once you've picked up the bucket, a full bucket, but you are not walking, and now you are walking, it becomes afterload, right? So when the load is acting on the muscle before the muscle begins to contract is preload, and when the load is acting after the muscle begins to contract, that means after stimulation, is what is afterload. In the preloaded condition, there is a decrease in inertia. There is already stretching of the series elastic component and the parallel elastic component. So a side stimulus will increase the force of contraction. So the force of contraction will be more with the preload and the latent period will be less with the preload. However, in the afterload, the load is acting after the muscle gets contracted. So in this condition, you will see that the amount of work done will be less as compared to the preload, right? Now, this term preload and afterload are very, very important when we consider heart. So in the case of heart, this preload is the end diastolic volume or the venous return, and in the case of heart, we say that it works on the Frank-Starling law, which says that within physiological limits, the force of contraction is directly proportional to the initial length of the cardiac muscle. So this initial length is the length available before the muscle begins to contract. That means the end diastolic volume or the venous return, right? And this is based upon the length tension relationship, right? This is based on the length tension relationship. Like the force frequency relationship is there, right? That increase in the force, increase in the frequency will increase the force of contraction due to calcium. Then there is NRIP effect, that is increase in the afterload increases the force of contraction. The Frank-Starling's law, that is the relationship between end diastolic volume and force of contraction, is the length tension relationship, right? Now afterload in the case of heart becomes the resistance against which the heart has to pump the blood. That is the total peripheral resistance. So if the person has got more amount of diastolic blood pressure or aortic stenosis, the afterload will be increased, right? And if the afterload increases, there is going to be a decrease in the cardiac output. जैसे आपको मैंने कल भी बताया था, when we say that the pressure in the left ventricle should become more than the pressure of the aorta for the valve to get open, this pressure was nothing but the diastolic pressure. So remember the NRIP effect, that increase in the afterload transiently will bring about increase in the force of contraction. क्षितिज समझ में आया? Yes, क्षितिज. Andan, end systolic volume is the amount of blood remaining in the ventricles after systole. After systole, not after depolarization. Depolarization is the electrical event, but systole is the mechanical event. समझा क्या बेटा? Kshitij, I have got my own Telegram group, Synapse for Success in Physiology. ठीक है? Or just ping me on Dr. Reena Kaur Ruprai on Telegram, and whatever I teach, I provide the PDF of this on my groups. So you can take those PDF from the groups, right? So you can get connected to me on my Telegram group, that is Synapse for Physiology, Synapse for Success in Physiology. And whatever else is to be taught, आप लिख सकते हैं मुझे, so that जब भी मैं YouTube लूँगी, so I can get come to you. And Shubham, thank you for answering so much. You make my work very, very easy, and I just came to know that you are very good learner. I hope you do best. Dark night, Please send me a message on my Telegram group. Just add on to it so that whatever PDF here I provide, I can give you the PDF in the form of PDF. I can provide you all that. ठीक है? ठीक है. So thank you for being wonderful learners, everyone, for making this session interactive, and hope we catch up soon. Very I'm waiting for your connection at the Telegram groups so that we can be more connected. Yes, Shubham, words have always to be kind. Best wishes and blessings to all of you. Bye-bye, and let's sign off. Good night and have a nice day and then happy learning. Thank you.